Well, again, good morning or good afternoon, depending where you are in the world. Is lunchtime for me. I am Marianna Biggi. I'm the head of VetCT Equine, and welcome to the first of this winter webinar series, which are organised by VetCT. Today we talk about dental radiography. I'm going to go through my presentation and then we can have a question section. If you go at the top of your screen, there is a Q&A chat box where you can put your question in. You can put it during the talk or afterwards, and we will go through them later. Don't use the chat box because that is not monitored, at least I won't be able to look at both, so please use the Q&A sessions. So talking about dental radiography today, and we're going to go through acquisition of imaging and image quality, and then we're gonna evaluate some imaging findings and differential diagnosis for those. First of all, we need to think about why we are taking radiographs of the head, specifically dental radiographs. And most likely it's because we have looked at the horse, so we had done an oral examination and we have found abnormalities which warrant radiographic examination. And or perhaps the horse has got nasal discharge, it's got mandibular swelling or discharging tract, or swelling, the formation of the head, facial swelling, or perhaps even oral pain and dysphagia. And based on which clinical sign we have detected, we can choose which radiographs we may want to obtain, which views we may want to obtain. And I'm saying that because taking all the projection that you can for the head might be quite expensive and time consuming, and therefore you can select specific views depending on what the horse is presented for. The first view we can obtain is the lateral view, and of course depending on where the lesion is, you can center it more rostral, more caudally. Not the entire head can be imaged at once, and therefore you need to choose which area you are more interested in. For all images of the head, and therefore for dental imaging, I would recommend to change your head color to a head rope color, so that doesn't cause quite as much artifacts. But actually, personally, if the horse is well behaved and is well sedated and stable, I quite like to remove completely the rope head collar, so that doesn't cause any artifacts at all. I like the head to have a sort of 45 degrees angle, like in this particular horse, and the nose position on the headstand, which should be at the height of the shoulder, and that makes the horse comfortable enough to stay basically on his own on the stand. If you have if the handler needs to hold the nose of the horse to keep it in position, then you will have to have gloves on, because they're hands are quite close to the primary beam. But I usually try to ask the handler to step away from the horse when the exposure is taken. As I said before, you can't really take the entirety of the head in one single projection unless you have a very small horse. So you need to choose which area to take. This left side image has been taken to evaluate the fracture of the incisor, while this one on the right-hand side is well, it's a bit more cool than I would like to be if I wanted to evaluate the teeth. So I think it's not an ideal view. To be honest, lateral view per se is one of those views that I don't find very useful to evaluate dental pathology per se, but is quite useful for sinus changes. So if you have nasal discharge, then it's useful to include it. But if you have if you don't have nasal discharge, perhaps it's one of those views that is not necessary. A DV view I really like for evaluation of the sinuses, but also for evaluation of subtle dental disease. And I'll go through some of the changes that may be seen in the DV view later on. Remember that you can obtain offset DV views, and that will allow you to move the mandible to one side or the other side, so then you can see all your maxillary cheek teeth without superimposition with the mandible. So you use a gag. This is one that I've taken from this paper, but there are different types you can use to move the mandible away, and that allows you, for example, if you have extracted the tooth, to evaluate if the entirety of the tooth has been removed, or sometimes when you have fracture of the teeth that are on the midline but you can't quite see them on the standard DV view. I think this is a projection to consider. Oblique views, I think they are the most useful for evaluation of the teeth, and what I see that's confused quite a few people is how to label those images. So I'm going to go through that and how the images are called. And that's because I find it quite difficult when I look at images remotely without having taken them to understand which views has been taken if the markers are not in the correct place. So we'll take oblique views from left to right, dorsal to ventral, for evaluation of the maxillary cheek teeth. So if you have a lesion on the right hand side, you will put the place on the right hand side of the horse, and you angle 35 degrees angle down from left to right. And this is the view that you should obtain. I think you should make sure to have all the 6 teeth in the image, so then all the teeth can be evaluated in one single view. So in this case, because we evaluate the right side, the right maxillary cheek tooth, then the right label goes dorsal to the nose. We can then do the opposite oblique view and to evaluate the left side. So this is going to be a right dorsal to left ventral oblique, and in this case we're going to highlight the left side, the left cheek teeth, and therefore the marker will still go dorsal to the nose, but it will be the left marker on this case. You don't have to acquire both views all the time. If you know there is nasal discharge on the left side, you can just acquire the left view, the right dorsal to left ventral view. But I think sometimes, especially when you have subtle changes, it's quite useful to have the other view for comparison. If you want to evaluate the mandible, then the projection is going to be from ventral to dorsal. So in this case, we want to evaluate the right mandible, and therefore we do a left ventral to right dorsal oblique views, and the marker R goes on the ventral aspect of the head to highlight the fact that we are looking at the right side of the mandibular cheek teeth. The angle in this case is 35 to 45 degrees, and that depends a little bit on the length of the teeth. I think I normally do 45 degrees. Just to highlight this again, if you have a lesion on the right side, and depending if it's on the mandible or on the maxilla, the plate goes on the right side. So the plate always goes closer to the area that you want to image. And then if you look at the maxillary, we're going to go dorsal to ventral. If you look at the mandible, we're going ventral to dorsal. Intraoral views are very useful for evaluation of the incisors, and I think if you actually have incisor pathology, this is probably the only views you need, unless you have maxillary, unless you have fractures. I don't think any other views are needed, and that is one example of how it should look like. Try to put the plate as far in as you can in the mouth. I know that's not always easy, but it's quite important to include all the incisors in the view. Please don't do it like they are doing in these pictures with no gloves behind the primary beam. This is not following the radiation protection rules. So the person holding the horse in this case should move away or at least wear gloves. So we now move on to interpretation, and I'm concentrating my talk on the maxillary cheek teeth and sinuses, and that's because I find it much more challenging to interpret than the mandible, but that's maybe just me. I think first of all, we'll probably need to think about the age of the horse that we're looking at, and that's because teeth do change from a young horse, like this is about, this is about a 4-year-old to this 8-year-old, and to this horse on the bottom right side, which is 26 years old. Not only the height of the teeth change dramatically with age, but also the shape of the roots is much rounder in a very young horse, and then it becomes more pointy in middle-aged horses. It's also quite useful to know the age, because some of the changes may be more relevant in younger horses than maybe in older horses. We do expect a certain degree of clubbing in old horses of the roots, and perhaps some small diastemata, and that just because of the shortening of the tooth that make these spaces become slightly wider than they are normally. This horse on the left-hand side, this was submitted a 12-year-old, but the more I look at this, I hope that this horse was not actually 12 years old. The teeth are far too short for a horse of 12 years of age, and of course this horse has been highly neglected, so the teeth are worn out probably more than expected for a horse of this age, but I still believe that this is probably a bit too much for such a young horse. As for any other region, when we evaluate radiographs, we'll need to know quite in detail the radiographic anatomy. One thing to remember, if we look at this picture on the right side, we have a maxillary cheek teeth and a mandibular cheek teeth. The maxillary teeth do have maxillary teeth do have 5 pulp, but also have 2 infundibular, while there are no infundibular in the mandibular cheek teeth. And therefore, if you do see gas within the tooth, that is going to be in the pulp, and therefore always pathological, while if you have gas in the maxillary, in a tooth in the maxillary region, then it could be infundibular or pulpar, and that can be differentiated because infundibular gas is not necessarily clinically significant. If we look at the picture of the left, we have an anatomy session, then we have radiographs, and then we have a CT. What I like to see in a normal horse is a very smooth and marginated tooth fruit, a nice and smooth and thin lamina duodentis, and a little loosened space between the lamina duodentis and the tooth fruit, which is the periodontal space, and that's where the periodontal ligament is located. And we can see the same thing on CT. And changes to the root, to the lamina duodentis in the periodontal space, we'll see in a minute, that can be related to infection. This paper looks at the sensitivity and specificity of radiological signs for diagnosis of periapical infection of the equine cheek teeth. They looked at there were 41 infected checked teeth and 41 control, and they looked at cropped images, so they looked at each tooth separately. So it's not quite the same way we would look at radiographs, but they look at a large number of changes for each tooth. We can see in this table what they looked at. And then they try to associate the sensitivity, calculate the sensitivity and specificity of each of this sign for the diagnosis of infection. And what they found was that the overall sensitivity of radiographs for diagnosis of infection was 76% and the specificity 90%. And I think this highlights the fact that actually it's still quite useful to take radiographs of the head and for dental infection, not just go straight to CT, because in many cases we will be able to make the diagnosis using these standard imaging system. However, if we look at the all the changes that they looked at, we can see that some changes were more sensitive than others for detecting infection. And the one that they looked at the most was periapical halo, which is a lucency around the tooth roots and widening of the periodontal space, as we can see in this case. Another factor that was looked at was the clubbing of the tooth roots, which is this change in shape of the tooth roots, as we can see in this case. And another factor that was associated with infection was periapical sclerosis. The author warned about some changes, like for example, the loss of the lamina dura dentis. Sometimes you can't quite see it all, and this was highly sensitive for detecting infection, but it was very, very poor in specificity, and the author recommends not to use this particular sign for diagnosis of infection because you don't want to remove many teeth that might be normal. Of course, we all know that removing a normal tooth will probably cause more problem than benefit. So we want to be pretty sure before we remove a tooth that is definitely infected. And concluding from this paper, periapical halo and periapical sclerosis are two findings that we should use for diagnosing apical infection. This is another paper that looked at comparative radiographic CT and then pathological and histopathological findings in horses with infection, again of the maxillary cheek teeth. They had 29 horses in the group, and what they found that it was that about 50% of the horses were diagnosed radiographically. I mean, all their horses underwent radiography and CT, but the authors determined that the tooth was infected based on radiographic only in about 50% of the teeth, and the others will had to have a CT for a complete diagnosis. And they explained this by the fact that many of the teeth had pulp or gas, and that was always present on CT, like in this example I have here, and this is quite difficult to see radiologically. This is one of those cases that when I read it, I find it quite challenging, because you do see changes which are suggestive of infection, but you are not quite sure if those are enough to justify extraction of that particular tooth, and then you wonder, would CT show me something else? So if we go look at this 09 tooth, we can see that on the mesial root, we can't quite see the margin of the root, and you can't see the lamina dura dentis, and there is a small amount of periapical sclerosis. And if you can compare it to the distal root, you can see the lamina dura dentis around the distal root, and there is no periapical sclerosis. There's also a little bit of fluid into the rostral maxillary sinus, as denoted by the asterisk. What I do like to do in these cases is to compare my oblique view with the DV view. This is the same tooth on the left-hand side. You can see that the distal root has a normal and nice lamina duodentis, while we lose it on the mesa root. So I think the changes are confirmed on both views. However, we know that this radiographic finding per se is not quite sensitive as others for diagnosis of infection. So I would probably still recommend CT in this particular horse. When we look at the teeth, we should also look at the opacity of the teeth and see if there is gas within it. As I said, I find diagnosis of pulp or gas quite difficult on radiographs, but of course you can see dilated infundibuli with radiographically. I also evaluate changes in shape of the tooth, which might indicate the tooth is dysplastic. Or there is cemental deposition at the around the roots. If we look at this horse, first of all, this is one of those cases where there is confusion which view is which. The image on the left-hand side is a right dorsal to left ventral oblique. So we should highlight the left maxillary cheek teeth. In fact, we have a left marker. But then you go on the image on the right side, which is the left dorsal to right ventral oblique, and you again have a left marker on the dorsal aspect. So this marker should have been right, and to make the process very confusing. And sometimes when you don't have specific lesion, it's quite difficult to know if the view is named wrong, and perhaps only one oblique view was obtained, of actually there were two views, but then the labeling is wrong. So pay attention on the labeling and your views. So then if your images are looked at by someone else or retrospectively, a few years later, and then you remember which view was which. In this particular case, I know that the two views were obtained because the teeth are different. There is a degree of periapical sclerosis surrounding both the A7 and A8, but what strikes my eyes the most is the shape of this 06, which is on the left side. You can see there is a large lucency within the tooth, which I'm not sure if it's pulp or infundibular at this stage. And the tooth root is definitely abnormal in shape, and we can see how round it is in the other oblique view. Maybe you can also think that there is a periapical halo, but I'm not quite convinced from this view only. DV view I found it very useful in this particular case because you can see that there is the formation of the maxillary bone and the lucency around the mesa roots of the 06, as we suspected on the oblique views. This horse did undergo CTs, and we can see that actually the exact same changes are seen on CT. There is the marked abnormality of the tooth roots with the formation of the maxillary bone and the alveolar bone suggestive of infection. There is gas, which we now can confirm is within the pulp. What CT is also helpful to determine is the significance, the other changes which we saw within the 07, 06 and 07, sorry, 07 and 08, which confirmed the presence of sclerosis, but perhaps those were not quite as significant as the infected to the 06 tooth. Diastemata is one of those things that often comes up in the history. These may have been spotted on oral examination, therefore radiographs are taken for further investigation. And in my experience, you do have often changes at the roots in in teeth that have diastemata. So like in this case, we have a space between this 08 and 09, and you can see a periapical halo associated with this tooth. This is quite an old horse, so you have actually periapical changes associated with multiple teeth. This diastemata actually is more quiescent, and these tooth roots, in my opinion, are normal. This is an interesting case. This is a 12 years old pony which had 2 years well, left side nasal discharge for 2 years, and actually since it was purchased 2 years ago, so the owner was not quite happy about this. And when radiographs were taken, there were quite dramatic changes. When we can see that the tooth has been removed and the 06 has drifted, trying to close the gap between the 06 and 08. I can't quite see a diastema in these radiographs, but I suppose there is, and that's because of the change that I can see dorsal to this within the nasal cavity. There is increased opacity, but that is not quite fluid opacity, in the sense that to me this has a sort of striated pattern. In addition to that, there are mineral opacities within these nasal cavities, and also more caudally dorsal to the root of the 07. You can see the location of the material on this DV view, which is actually rostral to the rostral maxillary sinus, mainly within the nasal cavity. So to me, this pattern is really typical of presence of food within the, well, in this case, the nasal cavity, but would look similar if it was in the sinuses. And in fact, this horse did undergo CT, and you can see the large fistula that was present at the level of the extracted tooth, and the large amount of food impacted within the nasal cavity. This is very chronic, as we can see by the dystrophic mineralization within the material, and also by the degree of deformation of the maxillary bone, nasal septum, and palate. Dental fracture is also a thing that comes up from history, because it's observed on dental examination, and then radiographs are taken to further evaluate dental fractures. If he has spotted a sagittal fracture, well, then a DV view is the most useful view for further evaluate the fracture itself. But of course, you want to know if there is infection of that particular tooth, and therefore oblique views will be required. This is an odd fracture that I have only seen once, and it's a transverse fracture. This was a traumatic fracture which occurred after this horse was attacked by a dog which was pulling on the bit, and traumatized this tooth. Dental fracture can be much more subtle, and we often see little buccal fractures on multiple cheek teeth. And I think this paper, of course, is a CT paper. We're talking about radiographs, but I think it's a quite interesting read, because we can correlate these findings to the radiographic findings. They looked at 87 sagittal fractures, and they looked at the prevalence of apical remodeling associated with this fracture. And the prevalence of remodeling was very high. 77% of all teeth with fracture had apical remodeling and signs of infection. All the sagittal fracture and teeth that had multiple fracture had remodeling, and up to 73% of the buccal fracture had apical changes, which is much higher than I would have thought. There was also no association between the fracture length and the presence of infection. So perhaps even if it's a small fracture, we should not ignore it. Of course, these are very difficult to evaluate radiologically, but if you do want to see the extent of the fracture radiologically, then open mouth oblique views that are shallow in angle are quite useful for evaluation of the clinical crown. This is a horse that was evaluated because they had multiple caries and multiple fractures, and every time that the dental was done, these were a little bit worse. So then there were radiographs were taken at this stage, and we can see one of the fracture on this 09. And we can see quite substantial periapical remodeling associated with this distal, mesial root of the 09, and you can see that the sclerosis can also be detected on the DV. So I'm quite happy that there is periapical remodeling associated with these tooth. There might be other fractures on other teeth, but I don't think he'll be confidently able to diagnose them based on this on these projections. Of course, if you do radiographs for dental disease, we can't really not look at the sinus at the same time, and that's because there is often pathology within the sinus associated with maxillary cheek teeth infection. Sinuses are sometimes difficult to, the limits of the sinus are sometimes difficult to see radiologically, but you can use this paper as a guide. This paper looks specifically at the dorsal conchoid volar, and so the dorsal nasal volar and the ventral nasal volar, but it also puts markers on the other sinuses, so then you can use as a reference. What I found a bit strange from this paper that they put a marker on the ventral conchoid sinus in this particular location, and I personally struggle to evaluate the ventral conchoid sinus on his own on the lateral view, and I would recommend to use a DV view to evaluate the ventral conchoid sinus. And usually if you do have material soft tissue opacity extending axial to the mandible, that means that there is affection of the ventral conchoid sinus. A sinus fluid can be quite easy to detect if you have multiple fluid lines. What I recommend is, first of all, to acquire the images with the head position at an angle compared to the floor, so that the head is not too extended, so then the fluid lines are very close to the roots of the teeth. And also, when you read the radiographs, to position the radiograph on your screen in the same orientation as it was taken. So then all the fluid lines are parallel to the bottom of your screen, and therefore is easier to spot. We can see multiple fluid line here, which are quite obvious, but sometimes you have only a little fluid line, perhaps in the rostromaxillary sinus, and that might not be quite as easy to detect. If you look at the image on the right side, this is something that can be quite confusing. This particular horse has changes associated with the 11 to 11, so you can see periapical sclerosis and widening of the periodontal space, and you can see this line, and if you don't look carefully, I think it'll be easy to interpret that as a fluid line. But of course I can see another line ventral to it, and then lucency ventral to it, which suggests that actually this is not a fluid line, and what that actually is just the infraorbital canal, which is in this particular horse was very straight, while many times is curved and therefore does not represent a problem. The shape of the infraorbital canal in this case could have been quite confusing. Sometimes instead of fluid line, we do have heterogeneous material filling the sinuses, and this is soft tissue mixed with gas, which is highly suggestive of abscess or impediment within the sinus, because the location of this material in the DV view, I think the ventral concha sinus is where this material is. And you can see that the material has expanded the sinus. Unfortunately, when you have this heterogeneous material, this also superimposed with the roots of the teeth, making interpretation of the tooth roots quite challenging. I think in this particular case, the O9 is not completely normal, and we can see that the distal root is poorly defined. We have lucency around it, but of course it's not quite as straightforward as it would be without the superimposition of this material. So I think I'm going to conclude, and then we can get on with some question. Of course, this is not an exhaustive talk of everything you can possibly see in the teeth, but some ideas on how you can get on to interpret radiographs. I think the most important thing to remember is that not all changes that we see radiographically are sensitive or most importantly specific for detecting dental infection. So let's try not to overinterpret changes that might be dubious and then remove teeth that perhaps don't need to be removed. However, if you do see periapical halo or periapical sclerosis, especially if severe, these are very useful findings and are very highly indicative of infection. So in these cases, there is no need of additional imaging such as CT. However, in some cases where the changes are very mild and perhaps not quite as obvious and in others, then CT is the way forward to make an exact diagnosis. Also, sometimes, especially if you have old horses with multiple infected teeth radiographically, it's quite difficult to determine which tooth exactly needs extraction, and I believe in these cases, then additional imaging is useful to at least increase the confidence that what treatment you're going to do is going to make the horse better. Well, thank you for listening, and if you have any questions, please put them in the Q&A session. I think you can probably ask them directly as well. If you want to unmute yourself and ask a question, please do. I have no questions so far. No question, anybody? Awesome. Well, I do have a question now, which is what findings will make you recommend CT versus sinoscopy? I don't really do oral examination, so I just go on the other end. So normally this has already been decided, but you mean based on on my radiographic findings. I think if you have radiographic evidence of sinus disease, then a sinoscopy is useful. But I'm not sure you can evaluate exactly the extent of the pathology by sinoscopy. I think CT gives you a better idea of the extent of the sinus pathology, and also can give you an idea of the dental changes that might be causing the sinus pathology better than, of course, sinoscopy won't be able to do. I think many of the time before horse is going to CT, or whether sinoscopy has already been performed, and CT is also been done in addition to that. Another question I have: do you find scintigraphy to be useful? My straightforward answer is no. You can diagnose dental disease using scintigraphy, but I consider scintigraphy is not much cheaper than CT. I would not recommend that as my first line of advanced imaging. Same way as I would not recommend MRI, because I think dental changes are much more difficult to diagnose using MRI than they are using CT. But of course, that depends what you have available. If that's the only technique you have available, then you can try and use it.
Hi, Marianna. We've got a question from Camilla Lumsden that's come through on the chat. How often do you think the radiographic periapical changes actually equate in periapical infection in buccal fractures?
How often do you think periapical radiographic changes relate to true periapical infection in buccal fractures? I think it's a difficult question, because you do have periapical changes which are related to the fracture, but if that's and are indicative of infection, but if that are going to be clinically relevant to the horse, that is a different matter. Because if you have a little bit of periapical remodeling and you don't have any oral pain or any nasal discharge, then you don't want to cure the radiographs, you want to cure the horse. So I think that is has to be interpreted based on the clinical findings rather than on the radiographs per se. I don't know if I've answered your question. But I think in many cases you have a degree of infection, but it's not of clinical significance, let's say. Ben, I don't really do treatment very much. This question was, what is your experience in using antibiotics as a first treatment? I don't normally recommend treatment. I only interpret images and radiographs. So I don't really know, sorry. Could you repeat your observation about gas pockets in maxillary versus mandibular teeth? Yes, so that was just an anatomic question, because I think when you study it, you don't really think about it. But in the maxillary cheek teeth, we have infundibuli, and infundibuli are often widened, and they often have gas, which may or may not be relevant for the horse. While in the mandible, we do not have infundibuli, and because infundibuli are not present, if you have gas in the mandible, has to be in the pulp, and therefore is indicative of infection. And that is true on radiographs, is true on CT. And that is something I don't think I had realised when I finished vet school until I thought about it more in depth. I think we can close this session for today. If you have any further question, you can send it through to VetCT, and I will try to answer you. Hopefully you have enjoyed this talk, and there are a few more coming through, so keep an eye on what else it will be available in the future. Thank you very much, and have good rest of the day.